Okay, well, thanks to those who have joined us, and welcome to today's webinar. This is When More Than One Outcome Matters, a method for precise accounting of multiple chronic conditions and a case study of patients with obstructive airway disease. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions. The two powerhouses are the Healthcare Systems Research Network and the Claude D. Pepper Older Americans Independent Centers, or Pepper Centers. As many know, the Aging Center is led by Dr. Jerry Gerwitz at University of Massachusetts and Meyer Primary Care Institute, along with co-PIs Elizabeth Bayless and Jay Magaziner. My name is Heather Whitson. I'm faculty in the Duke University Pepper Center, and I co-lead the Aging Initiative's Dissemination Workgroup along with Leah Hanson at HealthPartners. Before we get started with our talks today, I'm going to cover the technical details. Because there are so many registrants for the webinar, we do have lines on mute to reduce the audio feedback. So unless you're logged in as a panelist, your line is muted. But we do encourage audience participation, and we ask you to use the QA and chat functions in the webinar software. So if you're in your Cisco webinar portal, under the tab that says Presentation, you should be able to look at the upper right and see an icon for both chat and for Q&A. So if you have questions for the speakers, please use the Q&A function to submit your questions, and then Leah will keep an eye out for those questions, and as time permits, we'll read back as many questions as we receive and allow the speakers to answer those at the end of the presentation. Now, if you have technical or logistical questions, we ask that you submit those using the chat function. Please make sure to identify yourself by your name or participant ID if you see that, and that will help the webinar hosts be able to help troubleshoot any problems that you're having with audio or other technical issues. Whether you'd like your comments to be visible to all participants or only to the hosts. And speaking of the hosts, we extend a huge thanks to Catherine Anzuni as well as Valentina Landon, who are doing work behind the scenes to make these webinars possible. They will be monitoring the chat function. So without further ado, I would like to introduce our two speakers today. Screen's changed. Our first is Terry Murphy, and he received a BS in Biomedical and Electrical Engineering Technology from Temple University before spending 12 years in industry as a manufacturing and development engineer for the Eastman, Kodak, and Johnson & Johnson companies. His industry centered on clinical blood analyzers and introduced him to the world of FDA regulation and stringent requirements regarding statistical validation. After attaining a master's in statistics, he pursued advanced studies in engineering statistics, receiving a PhD in 2004 from the Georgia Institute of Technology. In September of 2005, he has worked as a biostatistician at the Yale Program on Aging, supporting investigators in geriatrics and pulmonology. Our next speaker will be Professor Heather Allore. Dr. Allore is from Yale School of Medicine, and she founded the field of gerontologic biostatistics. Discipline trains biostatisticians for conducting collaborative clinical research with geriatricians and gerontologists, as well as basic science aging researchers to provide the basis for the development of new statistical methodology. She leads the biostatistics core of the Yale Pepper Center, as well as Yale's Alzheimer's Disease Research Center Data Management and Statistics Core. So with that, I'm going to put myself on mute, and I'm going to turn it over to Dr. Murphy and Dr. Allore. Thank you.
Hello, Terry Murphy here. Catherine, can you help me get to my slides? Here we go. Okay, hello, folks. So the title of our webinar today is quite long. Important thing is that we're going to talk about several outcomes, and to see if you have several important explanatory variables, in our case, multiple chronic conditions, we show how we can parse their separate contributions to those outcomes. Based on a pilot award from the Aging Initiative. On the left is a photo of the Yale School of Medicine where myself and my co-presenter, Dr. Heather Allore, are. And on the bottom right is a photo of beautiful Danville, Pennsylvania, of the Geisinger Clinic, which is my two healthcare systems research network colleagues hail from. We are funded by the Aging Initiative, which is an R24 award with Jerry Gerwitz as the PI. So why do we think about multiple outcomes? And in clinical studies, we focus on single outcomes. But the truth is that any important life decision, you consider various different criteria. For instance, healthcare systems, with a lot of the talk recently of repeal and replacement of Obamacare, one has to think about accessibility, cost, and quality. You can't really have a satisfying solution just one of these outcomes. In regards to deciding on health care of older persons, you have to decide on the ramifications for future care and also the patient's quality of life. Methods do we have to consider multiple outcomes at one time? As I say, most studies look at a single primary outcome, and you may look at a secondary or tertiary outcome. There's no rigorous consensus on the best way to statistically and simultaneously evaluate multiple outcomes. There are a few tools, though, in the statistical toolbox. One is joint modeling of outcomes. There is joint latent trajectory modeling. Now, in the second presentation, Professor Allore will touch on these, some work she's done. I'm going to play more conservative and I'm going to look at several outcomes in my study, but basically looking at them separately. And so what I look for is consistency and complementarity in the things that we see in my group of outcomes. Now, the initiative is largely motivated by a desire to get a better handle on multiple chronic conditions. Those of us who work at Pepper Centers, this is in our bread and butter. We're always thinking of how multiple chronic conditions contribute to utilization, to patient outcomes, and as we grow older and we have more and more comorbidity, we have to deal with things like diabetes and cancer and diabetes, pardon me, and we live longer. Now, Mark is going to focus really on a precise way to sort out the of current chronic conditions to a single outcome. And I think it's helpful to think about what would a useful method of doing this, what would be some of its characteristics. And I think we want it to be active. We want the individual contributions of each coexisting condition. It to be able to handle a fairly large number of conditions. Like it to be model-driven based on data with a certain level of face validity. And there is a thing called the average attributable fraction, and it's limited to applications who have a dichotomous outcome and dichotomous conditions, the explanatory variables for a dichotomous outcome. The AAF was really well developed and fleshed out in 1995 by Ida and Gefeller, and they continued working on it. It does have good face validity. It's based on statistical models of data. It does yield additive contributions of the concurrent conditions. a little work here at Yale where we have extended it to handle a fairly large number of conditions, as well as to do a rigorous accounting for covariance. So I'd like to provide a little intuition about what the AF means. Funny, it represents the proportion of outcomes that could potentially be prevented by its removal. Now, and this is largely a kind of counterfactual. They can't ever completely remove an exposure, but it provides a nice conceptual way to think about it. So here's a little teaser. Some of this results from my pilot study that I'll talk about toward the end of my piece. A pilot study of U.S. adults with obstructive airway disease, removal of chronic obstructive pulmonary disease would potentially eliminate 22% of reported cases of incident decline in perceived health. So that's to give you an idea of what the AAF tells you. This is an improvement on the original attributable fraction submitted by Levin. I have a typo here. It was actually 1953. Levin's attributable fraction did not account for overlap among conditions. It meant it was non-additive, meaning that the separate contributions from different conditions could add up to more than 100%. So it really loses a fair amount of space validity. So the average attributable fraction takes care of that by averaging over many possible combinations. The AF is really powered by two characteristics coming from the data. First of all is the prevalence of a condition. So a condition with higher prevalence is more likely to lead to a higher average attributable fraction. Second important consideration, again from data, is when you build a multivariable model of the outcome, those conditions with stronger associations tend to yield the higher average attributable fraction. I was having a little non-response for a second on my computer. Okay, so back to slide 10. So here's another example from the index pilot study, which motivates this whole talk. And in consultation with my two pulmonologists from Geisinger, remember I'm at the Yale Pepper Center, and I have these two pulmonologists at Geisinger in Pennsylvania. They really have compassion for their patients with COPD, and they think it's important to look at patient-centered outcomes as well as utility. So 3 patient-centered outcomes that we had in our data and that they think are important are an indicator of 7 or more days in bed, incident loss of mobility, and the experience is incident decline in perceived health. Now, to emphasize the role that prevalence plays as strength of association, I'm going to contrast asthma and COPD. So data set is the condition of highest prevalence, 63%. However, out of those 3 patient-centered outcomes, it was associated with 7 or more days in bed. Contrast COPD, also highly prevalent at 50%. It has strong association with all 3 of those outcomes. So here's a little table kind of summarizing the presence, the strength associations, and resultant average attributable fractions. So In the last column, I have those same three patient-centered outcomes. And for the first outcome, asthma, which has a prevalence of 63% in the study sample, explained 8.2% of that particular outcome, and it did not explain anything in the other two outcomes. But it had no statistically significant association with the latter two outcomes. Okay? COP in the rightmost column, it has prevalence of 55%, and it's strong associations with each of the outcomes, and in the end, it has very strong average attributable fractions of each. And bottom, I kind of summarize this information. So asthma, which has high prevalence and weak association, has a low average attributable fraction. C has high prevalence and strong association, and it has larger average attributable fraction. So we calculate the average attributable fraction. Just that we build a line matrix of all the combinations of conditions, and we identify all the subsets of the conditions. We build a good logistic model of the outcome. So we have conditions, meaningful interactions, and covariates. And then look at each person who has a unique set of chronic conditions. We iteratively calculate the reduction in probability of the outcome by moving the condition of interest. We do this across each subset of each person's condition, which across all the person conditions have two flavors. If we want to stay with cross-sectional data, that's the traditional average attributable fraction. If we longitudinal data, with the longitudinal extension of the AAF. Range of outcomes, we started 6 years ago. Mary Tonetti was interested in getting an empiric method of deriving the contributions of chronic conditions to mortality. Our colleague Manisha Mehta at Yale, she applied this to pneumonia requiring hospitalization. And last few slides, I'll summarize how I've applied this to a total of 7 outcomes. 4 are utilization, and 3 are patient-centered. So it is limited dichotomous outcomes, but we have quite a few of those we can choose from. Originally, part of why we were drawn to this was Mary Tonetti wanted to look at mortality, and the rules used by National Center for Health Statistics, they're based on an algorithm. They single condition, they for certain categories, such as cancer and cardiovascular disease, and they underestimate others, such as dementia and injury. And lastly, and of most importance to those of us in the aging business, they really don't do a good consideration of multiple chronic conditions. So we did a more empirical method with properties, and we found that the average attributable fraction really met all of these goals. A paper we published in Statistics in Medicine in 2012, kind of a follow-up to Mary Tonetti's paper, where we took the 10 most common groupings of diseases from NCHS, compared their numbers to ours using LEAF, using CS data, claims-based. A couple interesting things. Cardiovascular is top for both methods. We showed cancer as being making less of a contribution, but showed respiratory disease and lung disease is making quite a much larger contribution. And dementia, ours was nearly double what the NCHS said. Okay, so you've been very patient. It's been largely statistical to this point. Now we're going to get into the meat of my pilot study, and I've switched the order of the photos here. Now on your left, the beautiful Pennsylvania on the banks of the Susquehanna, and right you see the Key Museum of Rare Books at Yale, which has the Vermont marble instead of windows to protect its manuscript. Are Dr. Heather Allore, the next speaker. She provided the data from MEPS as part of her R01. Our own Gail McAvey is an epidemiologist, PI, and our two pulmonologists from Geisinger are Paul Simonelli and Jason Stam. Again, this was funded by the R24 of the Aging Initiative. I've got support from Heather Allore's R1, and also our own Pepper Center with our PI, Tom Gill. So CAAFE was the name of mine. It was the average attributable fraction for multiple conditions. Looking at U.S. adults with obstructive airway disease, they're folks with either asthma or COPD or both, know that they have a high burden of chronic conditions. They're super users of healthcare. These conditions strongly affect quality of life. And in general, we feel that they're often always receive the research interest deserved. We did the proportions of these outcomes that we could attribute to COPD and asthma, as well as the 10 most commonly occurring medical conditions. To base this on a large national cohort with good data on the chronic conditions. Turns out the medical expenditure panel survey is good for this purpose. Large, nationally representative, has good information on comorbidity. We did it to persons 40 and older, and we have a sample size of just under 3,500. Here's a diagram of our sample, and in MEPS with 89,000, we throw out lots of them for being less than 40, lots for not having either COPD or asthma, and we end up with about 46% with asthma, 37% with COPD alone, and 70% with both asthma and COPD. We define COPD as one or both of these identifiable conditions in round one, either chronic bronchitis, you been diagnosed in the last 12 months, or emphysema. Asthma is similar. Have you been diagnosed or still have asthma? And for other chronic conditions, the 10 other conditions, have you ever been told by an MD or other provider that you have this condition? Utilization outcomes are at 4 of them, and visit to the emergency room and cause hospitalization, sick or outpatient visits, and respiratory-specific hospitalization. The latter is the lowest incidence, and the high utilization rate of outpatient is highest in an outcome. We also had 3 patient-centered outcomes. These had incidences over 1 year ranging from 14% incident loss of mobility to 27% for 7 or more days of disability in the past year. Here are our 12 conditions conditions, so we include asthma and COPD here, but there are 10 others, and range in prevalence from lung cancer, which is very low, 1.4%, up to asthma, which is the highest. So here are the results for the four different utilization outcomes. It turned out that COPD made the largest contribution in 3 out of 4 of those. In the fourth outcome, arthritis was the largest contributor, and the other 3, it was the second largest contributor. Impairment in diabetes contributed to all 4, and hypertension contributes to 3 of 4. So, again, in terms of multiple outcomes, I'm seeing a great deal of consistency here in that arthritis and COPD seem to be the big players. COPD is slightly more important in this pool of 4 utilization outcomes. How to interpret the average attributable fractions for these outcomes? Remove COPD from U.S. adults with obstructive disease, which again is an imaginary situation because that would take away most of the people with obstructive airway disease. These range from 5.9% for the outpatient visits up to 20% for any ER visit. So COPD playing a large role in the utilization. Arthritis, which was the second biggest contributor, also making 11% contribution to the respiratory hospitalizations and a high of 19.7% to the outpatient visits. So this is the outcome where arthritis actually is stronger than COPD. But across these 4 outcomes, COPD and arthritis dominating. For my patient-centered outcomes, there were 3. Arthritis was the largest contributor in 2 out of 3. And third, COPD was the largest, and the other 2, COPD was the second largest. Now, for this domain of outcomes, cognitive impairment and stroke were also associated. They made positive contributions to all 3 outcomes. Here again, trying to supply a little simple interpretation. Arthritis from this cohort would potentially reduce incidence of 7 or more disability days by about 24%, instability by 29%, and incident decline in perceived health by 15%. Arthritis first because it was the dominant player in the patient-centered outcomes. COPD was the second contributor, and we see here that it makes a real big contribution to incident decline in perceived health. This is the outcome where COPD is stronger than arthritis. But still, across the domain, dominant contributions from COPD and arthritis. Including my study, COPD was the largest contributor to utilization, arthritis the largest to patient-centered outcomes, with a small number of other chronic conditions that made contributions, significant contributions that are non-zero. And in aggregate, 12 medical conditions explain between 52 and 61% of utilization outcomes, and between 53 and 60% of the patient-centered outcomes. Multiple outcomes, we did find consistent results across 2 domains. We had 4 healthcare outcomes, utilization outcomes. We had patient-centered outcomes, P and arthritis dominated across all 7. The average attributable fraction was a useful approach here, and a discussion of the paper that's under review. Jason Stamett Geisinger, really nice little discussion where he said the pulmonologist treating folks with obstructive airway disease prioritizes the treatment of their lung disease. Musculoskeletal considerations are important to both utilization and outcomes. There is a small number of the chronic conditions that make significant contributions. And here are references. And again, thank you for your patience. We were a little slow getting started on our end with some technical stuff, but I think with that. Catherine or someone else to either steer me some questions or tell me to proceed.
There's one question here related to your project. It said, since asthma and COPD are not always well clarified in clinical records, had the group confirm the difference between asthma and COPD, particularly in older adults?
Okay, so one of our primary limitations is the self-reported. This is reported on the part of EPS. They call a family and they interview a family. So the assumption is the person is reporting correctly, and on that, the person is reporting that they were diagnosed. So it's an error issue that's a primary limitation of this study.
And there's another question here. What was the time frame of the MEPS data used in this study?
So the MEPS data is cohorts that start individual years. We used the cohort starting between 2008 and 2011, and we pooled those and followed each of those persons for 1 year. So 2008 and 2012 altogether.
And we'll take, I think, you're chiming in. I don't want to step on your toes.
Okay, you're doing great at reading the questions. I just wanted to ask a follow-up, Terry, to the question about the self-report of asthma and COPD. Do you feel like you got more? Would you expect if you looked at clinical records you might see found a larger population or a smaller population?
If we'd looked at those records, we might have found larger. One of Paul Stein, Elliot Geisinger, he voiced the concern early on that method of self-reporting might miss a substantial proportion of the cases. So it argues if we did a thorough check of records, we would have uncovered quite a few more.
So I have another question asking how outcomes longitudinally in your data set?
So what we did was we just took a single year from each person. So this is only nominally longitudinal in that the explanatory variables are measured round 1, which is the baseline of each of those specific cohorts, and the outcome is just a 0-1 occurrence of the outcome within the year following that baseline interview. The technique, the AAF, you can apply it to multiple years of data, but we applied it to a single year in this case because it took us quite a while to get our hands around the data and working.
And we have a question Is there any mechanistic study as an ancillary to this one?
I don't believe there is. The PD is a very difficult creature to study. There's a lot of opinion about diagnosis and drug treatment, so no, to my knowledge, there is not.
Okay. The question was the method validated using other data sets?
We didn't validate it this particular time, but we've, as I put in the slides, we've compared it to the National Center of Health Statistics for Mortality, and we've also applied it, to a number of different outcomes. Heather Allore will present a few more outcomes she checked, but it's difficult because, it's assuming that there's some other empirically based method that other folks are using to come up with these contributions. So we've validated it in the sense that we've used it across probably 5 or 6 different data sets across a number of different outcomes and really come up with what's believed to be very credible and valid data. I'm not aware of a competing method to compare it against.
Okay, I think that's all the questions we have for now. Why don't we move on to Heather Allore's presentation?
Everyone, this is Heather Allore, and I am doing the plus this. And I'm just want us to kind of come back and focus for a moment on the idea of more than one outcome mattering. And here's a photograph of a family friend of mine, and we can think about her as her sum of mobility, limitations, her frailty, her vision impairments, a whole laundry list of medical conditions or medications she may be taking. But really, the outcomes that matter to her are her meeting her goals in life, her happiness, her social involvement. And this is a picture of her visiting me and my brother in Australia recently for her lifelong dream of seeing the Great Barrier Reef. So maybe we need to view people as more than organ endpoints. How do I go forward? Okay. I also have acknowledgments. I'm going to be sharing with you the result of different studies that are funded by a wide variety of mechanisms, including Whitson's Aging Initiative. And highlighting underlying analytic parts, but you're not going to see any equations, so keep calm and love biostatistics. So when we're talking about multiple outcomes, I'm really going to be using a language that Mary Tonetti, who we've had the great honor to work with for a number of years, has coined. That's this universal health outcome. And because it really is quite a challenge. What happens when you're really trying to look across different conditions and you're not just, an organ endpoint isn't going to cut it because all conditions don't point to the same organ. So the concept of these universal health outcomes that are important to patients, they're meaningful, they can be noticed by them. I'm going to be sharing some results that we've published in the past couple of years on self-rated health, survival, and function. Also that to highlight that adults value more than a single outcome. And be highlighted by some work of Terry Freed that she published a couple years ago, looking at health outcome priorities of older people with multiple chronic conditions, and if they were just ranking independent, staying alive, pain relief, and symptoms. If you look at the leftmost column, you'd see their first most important of those, just themselves, 76% endorse independence as their primary, while 11% endorse staying alive as their priority. If you look within those, you'll see there's a number of different orderings. And to me, the important part of this is, one, understanding the priorities of these older adults, but also recognizing they don't all have to be the same. So we're looking at multiple outcomes. I think we need to be bearing what our patients and the people in the community are feeling is most important to them. So here we are, we're biostatisticians, Terry and myself. So we view the world as a bunch of analytic challenges when we're trying to help answer clinical questions. And so right now I'm going to put things in the context of trying to assess the effects of treatment. And so, as I said, we can't really just focus on condition-specific outcomes. There are so many different combinations of conditions and treatments. What are we to do? And there's often multiple medications for any given treatment, and these medications may change over time, as well as the person's health or prevention of that disease may change over time naturally or in response to their medications. And so we need to have methods that are going to allow for changes over time, both in exposure to treatment, progression of disease, development of other diseases, and a variety of other covariates. But these are real characteristics of the person. So earlier we heard Dr. Murphy talk about the interpretation of this longitudinal extension of that average attributable fraction. Basically, I'm just going to quickly handles a large number of variables. We do allow them to change over time, and it is providing that absolute amount of that outcome that could be changed. So put that in another context. Terry was really summarizing very nicely for his pilot on COPD and asthma. But if you're looking at a population, think about your healthcare system. One is if you that is the change in an outcome that could be expected from a perfect treatment. Because what would a perfect treatment do? It would essentially eliminate that condition, or perfect prevention, right? And we're going to get there, well, maybe someday, but not right now. And so if you're really trying to see how much could I expect to change some outcome, that's the most that I'm going to get. So let's just think I'm going to be sharing some of the work we've done on these outcomes of cited health, mortality, and function. So I'm just going to kind of and we're going to be doing this in the setting of guideline medications. From the literature that 20% of persons receiving one or more guideline medications may actually harm a coexisting condition, and that the risk of adverse events increases each time another medication is hit, and by the time you get to medications, you're pretty much likely to have some sort of adverse effect. And we also know that there isn't a lot of clinical trial evidence really can be extended to both older adults and older adults with multiple chronic conditions. Sharing some of the work led by Mary Tonetti involving our group, looking at Medicare current beneficiary survey participants and looking at the effects of guideline medications for 9 common chronic conditions that have oral medications. And so this is just a table kind of laying out some of the conditions are along the top, but also if you look at the bottom left side, you can kind of see how they co-occur with a number of other conditions. Something maybe to point out in all of this, because the MCBS is nationally representative, we can see that around 50% of the elders, those 60 and older in this sample, have yearly incomes less than $25,000. And around, not quite, around 70% have prescription drug coverage. So, it does kind of give you a clue into another way that we're going to be contrasting and kind of really trying to, without really looking under the hood at the methods very much, another way to try and get our hands around analyzing multiple chronic conditions is to look at some of these co-occurring quartets of conditions. So we can see here under the conditions on the left-hand column, these are commonly occurring conditions together, and then across the top we see the classes of guideline recommended medications for these different ones. So you can see that sometimes it's stable. There is some variation in them, but gives you a little insight into it. Now looking at self-rated health, because way back in the beginning I always try and think of Mrs. C, and she wanted to have good health, right? Who doesn't want to have good health? So look at this. These are some of these longitudinal average attributable fractions. These are over a baseline and 3 years of follow-up. They're adjusted for quite a few variables there, kind of at the bottom right corner of the screen. And we see that, no big surprise, that conditions contribute a negative value, so they'll contribute to poor or fair health. The direction we generally want to go, except for hyperlipidemia, which is not symptomatic, so you're not really feeling that. We find out with medication, well, positive value, we want to have things in a positive value, but we want that confidence interval not to contain 0. Well, anything that significantly contributes of these medications to good to excellent self-rated health, though we do see some that do contribute in an additive manner to poor to fair health, and that be our thiazides, warfarin, and clopidogrel. Oh, okay, so we looked at maybe you don't feel good, but you do have these diseases. Remember, these are additive. All those numbers are additive and fully adjusted for a wide range of conditions. Okay, maybe medications for these aren't going to be the thing that makes you feel better. But may help you stay alive. So we use a different model to answer that question. So the most important thing is what's the best model to use all the time? The best thing to do is what is the appropriate model to answer the question at hand and to make those results clinically interpretable. So we're going to be using a type of survival model called a Cox regression, and we're then going to be looking at those sets of the combination of the 4 conditions, medications to vary over time, and we're going, since these are chronic conditions, we're going to allow people to develop new conditions over time, but we all know you don't get rid of them. So first I'll show you the results in a survival fashion and as a longitudinal average attributable fraction. So Dr. Tonetti and a group, our group published this, I guess now 2 years ago. Now, this is kind of small to read. You can go read the article if you're dying to know about it, but really the only thing I want you to be looking at here is patterns, because we can all see the patterns on the slide. So let's look at the top right corner, and we're going to see statins there. And look at statins. We can go across the row, and we'll just take that first blue line, and that's for coronary artery disease. And we see at the bottom of that gray box, it's on the side that favors survival. Okay, it doesn't cross that vertical blue line, so it's significant. We do have the adjusted value to the side. What does that really mean? That the row is its own model. That row says everyone in that row has coronary artery disease. Everyone in this study has at least 2 of these 9 conditions. So everyone has coronary artery disease. They have 1 or more conditions, which are terms in the model. So in this case, we're looking at a box that's about statins. Okay? So this is looking at those with coronary artery disease that take statins relative to those who don't take statins. Now, remember, they had the other diseases, and we also model the other guideline medication classes for the other diseases they have. So we're adjusting fully for that. And we have a big laundry list of important covariates, and so we see it has a protective effect. Now let's go down a little ways on that same upper right box, and we'll see the common coexisting conditions. So all of those under there are combinations of 4 diseases, chronic diseases, that include C. Now, once we start to focus the model, so those are now going to be a subset of the people who were in that original estimate. So when we start to focus this, so everybody has to have those 4. They can have more than 4. Have to have those 4. And remember, older adults, Medicare beneficiaries with 4 or more conditions are the highest cost utilizers, right? So we have these groups of 4, and now I'm going to look at that effect of statins, and suddenly see for 2 sets of eliminations, I lose that significant survival effect. Really, what I, as a biostatistician, I'm trying to present something that's clinically meaningful to audiences and the readership. But what I'm trying to tell you from a methodology standpoint is to really look that you have to answer the question appropriately. You have to be aware of how those models are working. So always try and collaborate with a biostatistician at your institution. So when we look at some of these cardiovascular conditions, same data set that we've been seeing from self-rated health and survival. So what happens if we look at from the absolute that we might be able to contribute? So we see the diseases that AFib and heart failure contribute to death. We can quantify those. We're here looking to see if those 65 to 79 basically have different effects than those above 80. And really seeing large effects there. But we are seeing that overall there is some survival benefit of these 3 medications. Our team picked these 3 medications because they had very similar prevalences. So as Terry pointed out, we want to take away the driver of the prevalences to really be able to pick up on the side that is the contribution to survival. So we focused it in that manner. So not function, okay? So not feeling that great with the meds aren't really helping with that, but many of them are helping you live longer. How's your function? Then same group. We're looking at functional disability. In the second bullet down on the slide, we see these are not just basic activities. They're not quite IADLs, but the physical activities recorded in MCCs. And so we're defining disability as being unable to perform the activity. And again, here, I don't want to dwell on it, but it's another type of survival method that's being used here, but because we only see things every year, because of the sampling scheme, it's called interval censored. I don't know at which point at interval something happens, but I know if it's still existing at the time point I observe it. We have repeat observations for each of the participants for the follow-up period. So just a real quick overview of this paper that's under review on this. Here we're putting them into those based on polypharmacy, since the mean number of medications was around 7. So low is less than medications. You might be thinking, boy, that seems like a lot. Older adults often seem to take a lot of medicines, and taking 7 or more. So again, let's look at our line here. The vertical line would be is at 1, meaning no effect. And so if let's look at our left panel, let's just down to the bottom and pick on statins again. If I looked at coronary artery disease, whether you're on low polypharmacy or high polypharmacy, no effect, no relationship to functional decline. Or if I looked at statins for those persons with diabetes, I see those that are taking less than 7 medicines, we do see an increased risk of functional decline, while those taking greater than 7 are not exhibiting this. We restricted it. We did a sensitivity where we removed persons that were taking insulin, and these results remained about the same. About the other notable result on this is that for persons with low polypharmacy, taking a renin-angiotensin blocker, they did seem to have a protective effect on functional decline, but we didn't see that among those with higher amounts of medications. Now, so we've now kind of contrast. We've gone through kind of another set of 3 outcomes, but they weren't really connected. Okay? And Terry laid out the importance of trying to move to connecting some of these. So focus on medications, and I'm just going to kind of, again, recontextualize us before we go forward and look at how we're trying to put some of these together. So medication, why is this important, right? Well, we have almost 27% of older adults hospitalized annually. They have the longest length of stay, a little over 5 days. They have the highest cost per stay at around $13,000. And Medicare beneficiaries, right? So the top one has all sorts of advantage plans, etc. But of the Medicare beneficiaries, the numbers I'm just showing were based on Medicare beneficiaries. We're seeing even higher hospitalization rates, 39%, and total hospitalization costs of over $14 million a year. Oh dear. And so when we think about the vulnerability of persons, we really want to think about also our persons with dementia that are having twice the hospitalization rate. That work came out of one of our healthcare systems research partners out of Group Health. And we know that the majority of inpatients with dementia have significant adverse outcomes, including function, rehospitalization, and mortality, generally outcomes that are not favored by older adults. And that there's evidence that some hospitalizations and their complications are potentially avoidable. So how do we kind of move towards this? Are some of the things that we could be using LEAF or other methods for starting tell us how much we might be able to avoid? There's some published work saying about 30% of admissions in older adults are attributed to inappropriate prescribing, and so what would that be? Or is that, some define it as polypharmacy or hyperpolypharmacy, 10 or more drugs, or classes of medication, such as cholinergics or things on the Beers list, been shown to be associated with functional decline and other negative outcomes. And there's been research showing that medications may be the most reversible cause of declining cognition and physical function, and these be not that there is, it is the medications that may be associated with these declines. I want to point to a clinical trial that I participated in with colleagues in the Netherlands, where they were looking at a comprehensive geriatric assessment for both randomized arms, with the treatment arm additionally receiving a transitional care plan, which was set up by a geriatric team during hospitalization to develop person-specific care and treatment plans, which would be carried out after discharge, whether to home or a skilled nursing facility, with visit day 2 and then at weeks 2, 6, 12, and 24. And persons across a range of MMSEs were included. We had a stratified randomization, and they also were selecting seniors at risk of hospitalization so that they could pick up on the risk of ADL and functional decline. Now, their primary outcomes were really ADL and cognition. News did not really move those outcomes. Our news was the number needed to prevent one death was 16 persons, and you see it started very early, and it stayed intact up to 6 months. And so one of the things that really was a major driver of this, remember that intervention was really standardly tailored for each person by a treatment team during the hospitalization. The one thing that was most common across all these plans in the treatment arm, in the intervention arm, was medication reconciliation in the home. So now we have this evidence that we're seeing function going with mortality. We're trying to pull these things together. And I really want to highlight some work that Terry Murphy published now about 2 years ago on different sorts of methods to do this. So if you're at the leftmost panel here, there'll be now you have here, this is the Tom Gill's Precipitating Events Project data. And every month the functional status and survival status of participant is measured. This is a method of showing there were two people the same race, gender, they were aged the same at baseline, and they had the same baseline frailty status. And just looking at survival, the leftmost panel says, okay, we're just looking at what's my probability of surviving in each month. And it doesn't really look any different. Now, kind of in the middle of the slide, after 91 months, levels of disability start to change between these women, and they have a slightly, just a constant difference in survival. So for over 1 month, they really looked very, very identical. Okay. Now, what happens when you, in the middle panel, when you have a survival model, you're now updating with what the disability status is. And you start to see somewhere right around a little before 100 months, right? So right about when they start to change, you see that that survival of the one woman seems to dip down the other, but you have very wide confidence intervals, so they never look different. But what he did that was really unique, and this is the first time this was ever done, and it's by being able to apply a Bayesian joint modeling approach here, able to simultaneously model on a personal level the survival and disability. Are simultaneously estimated where information about disability status is informing survival and vice versa. You guys measures, and you see very early departures, significant differences between groups at a person level early on by his choice of modeling. So that's where I again urge you to be thinking about what question you're trying to answer and what is the best method to be able to get to where you're trying to go. Okay, now I'm going to show you a different sort of joint modeling approach using aging class trajectories. We're doing this, again, we're going to stay in our theme of functional disabilities. So we're going to be looking at ADL trajectories over 5 years using National Health and Aging Trend Study. And so what did we want to do? We really wanted to be putting it in the context of diseases that have complicated self-care components. And so initially we're starting with diabetes and heart disease, and really trying to then say, does your cognitive status influence in some way? So if the thing about the NHATS data is they have validated tools for cognitive status so that each participant is classified as normal, possible dementia, or probable dementia. Do a tool for that. And in the setting of possible or probable dementia, you have more trouble with self-care. So maybe you're going to have some difference in function. And and also we know that these individuals may be also at higher risk of dying, not being able to function well enough to continue to participate. And that's why we jointly model the attrition over the 5 years with the functional trajectories. Now, another fantastic thing about NHATS data is that it has sampling weights, so you can generalize to the U.S. population. So let's first look at trajectories over the 5 years of follow-up. We would see there's 3 major trajectories, one that really shows very stable and no disability, a level of mild increasing, and then a level that starts, we only look at 6 items here, and goes to around 5. Now, what happens when we look at attrition simultaneously? Well, pretty stable attrition. You can die with no disability, lots of reasons, and can also drop out. And here we see that those with severe disability by 5 years after follow-up, we really have not even 23% of them anymore. So that may be very important in the modeling of trying to look at. Now, what's going on here, and really all I want to be able to show you in this under review is that we can see as those of the very top rows are no dementia, that in those cases we're really seeing only combinations with diabetes really driving any sorts of association to mild or severe trajectories. But once a person has possible and most likely probable dementias, we're really seeing them shifted much more to those severe disability trajectories. So another way to start to jointly model and look at combinations of multiple chronic conditions. Another way that we did it is something called multiple trajectories. So these are multiple latent class trajectories simultaneously estimated. So Xiao Xu, who's also here at Yale, using the health and retirement study. And over 12 years, many of you are aware of the thinking, moving, feeding construct here. And so she was doing these simultaneous estimation of these late class trajectories so that a person we would look column-wise here, and a participant would essentially be described as those three trajectories in a column. We use this to talk about socioeconomic factors, but there's a number of different ways that you can be looking at things that happen simultaneously and they represent characteristics of the phenomena you're trying to describe. So I'm just going to briefly touch on our ongoing work. So we are continuing to develop different approaches to joint modeling, so pairwise, 2 outcomes at a time, using different sorts of methods, Bayesian, non-Bayesian methods. We continue to use our universal health outcomes as well as utilization outcomes. And so I don't want you to feel like we're leaving you without any tools that are going to move towards helping people in the clinical world address these questions. So Terry Murphy and others here at Yale have been working on a project with me on individualized absolute risk calculators for persons with multiple chronic conditions. And just a quick screenshot here of a mock-up. COPD is our current target condition that we've been developing this on. But what we're really doing is we're biostatisticians, we're methodologists. We collaborate with clinicians in a wide variety of fields. Here we're working with a geriatrician pulmonologist at Yale, Dr. Fragoso, and we're developing the methods under this. And what is this? This would be a tool that the physician and patient could use together when trying to discuss treatment options. So patient characteristics, if we look at the upper left corner, patient characteristics that are appropriate. This is just a mock-up. This isn't the final tool. And then coexisting conditions. And what are the potential treatments that would be appropriate that the physician would be able to make a decision about? But in the upper right side, what are the outcomes that are important to that patient in dialogue? And displayed is that actual probability of each of those outcomes. And so this is in mock-up we see for a treatment of inhaled steroids, there's the probability of ADL disability is 1, the probability of worsening perceived health is 0.2, and the probability of going to the hospital is 0.05. And we show them in sort of a bar-like manner. And then you see another example for smoking cessation. This allows each patient to dialogue with their care provider on what's important to them, instead of saying what's just the best medication overall. So I'd really like to open this up to the healthcare system and the research network, because this is a tool we're developing the methodology and the interfaces for this, but be quite appropriate for your own formularies, for your own patient bases. We could work with you to estimate your own underlying absolute risk on these concurrent outcomes that patients are facing to develop a tool instead of just telling you it's complicated with multiple chronic conditions. Medications don't always act the same. Why don't we start to move to working with you to answer the questions you're facing. So with that, I thank you very much for your attention, and I will open it up to our moderators to handle questions, and thank you very much.
Thank you, Heather. Start with the first question is about the absolute risk calculator. In terms of years, is that absolute risk in 1 year, 5 year, 10 years? Can you talk about the time frame?
Oh, yeah. We've been to do estimates on any amount of time. We've been working this up with MEPS data on 1 year risk because working with our clinical colleagues, that seems to be the period of time they would expect to be trying to get some feedback on whether the medication was the appropriate dose and effective, was the patient tolerating it. And so although the methodology doesn't care what the time period is, we were trying to make it a clinically meaningful time point for a treatment decision.
Thank you for that clarification. And now another clarifying point, the question is, does modeling assume that an exposure or a treatment would have an effect on all outcomes in the same direction? What treatment prevents death but increases disability is the power compromise?
No, it's not. And I'm going to let Terry Murphy and I are in the same office. I'm going to let him address that as well.
Sure, that's a great question. So with modeling, the frame of reference is usually you build a separate model of each of the outcomes, and you add a person-specific random intercept that shares information between them. So it's entirely possible to have opposite sign associations between an explanatory variable and each of the outcomes. Joined together generally results in greater power for the lower incidence outcome that has, for instance, for modeling, Heather showed an example of modeling of monthly occurrence of death and functional status. The functional status being, an ordinal variable, and the occurrence of death being bottom is 0, 1. The function had more information, and therefore it improved the precision and the estimates within the other model. Answering the question? Okay, I know.
If you're not, maybe the person could type in some clarifying questions.
But in short, they can have different signs, and in general, joining them together should result in improved precision for at least one of the outcomes.
And a technical question. In trajectory, how many quarture usually do you use?
Different trajectories do we decide? Is that the question?
The word quarture, I don't know, Q-A-R-T-U-R-E.
Maybe it's yours. So there's a number of different ways that a person can do this, right? So, yeah, sometimes you can do trajectories looking at splines, and then figure out how many knots, or quadrant points. But possibly there also is a question about how are you deciding if it's an intercept only, like we saw the no disability group just was at 0 and stayed at 0. How do you decide if it's a linear association or a quadratic association or a cubic? Like, how many curves should there be in a line, right? So, so I'm not exactly sure which question I'm answering, but we do have methods based on a variety of fit statistics that allow us to tell if there should be a straight line or a line with one or more curves to it. So, so it is, without going into a lot of painful detail on how to do this, there are fit methods. It is an iterative fitting method to try and figure out how many underlying groups there are, and then what are the shapes of those groups. Fortunately, there's not just a button you hit and they pop right out.
Thank you. The question has to do with how you adjust for multiple comparisons. So because you're considering so many different combinations of comorbidities, are you making adjustments for those multiple comparisons?
So one of the nice things is when you simultaneously or jointly estimate something, it would kind of conceptually think about it, they're all in this model, okay? So unlike when you're doing separate outcomes, not sharing information across each other. As Terry just described about either a shared random effect, there's a number of different ways we share information. Then actually you may have a larger problems with inflating your type 1 error. So this is actually a very nice method to be able to not have such a inflation of your type 1 error. And yes, even in that BMJ screenshot I gave you, I didn't want to go into all the painful methods there, but we do routinely adjust for multiple comparisons in our effect estimate.
Are didactic resources for joint modeling of outcomes?
There is some literature, but it's largely in the statistical world, and it tends to be mathematical, so it's an easy thing to get into. At the risk of being shamelessly self-promotional, I did make quite an effort to try to write something that was conceptual, understandable in a paper that Heather referenced. A very nice paper was won by Brad Carlin and one of his students in American Statistician back in 2005. And also, I think, a very nice textbook by Demetrius Rizopoulos. If you Google joint models and put Demetrius Rizopoulos, do your best with the spelling. It's a Greek name. He's in the Netherlands. He's really a leader in this area, and I really recommend that you read his stuff.
So much. And we have some specific questions other about your slides. Can you go back to slide 13 on your presentation?
I'll try. There.
Okay, the question is, over what period of time was survival measured?
I believe we had a 4-year follow-up.
Great. And if you go back to slide 11. There's some great specific questions here. On slide 11, did you have a reference category for the condition and medication on LEAAF for self-rated health?
Do you have a reference
category?
Because if Heather will permit me to jump in, Terry Murphy, I didn't work on this, but I've worked with the LEAF enough to know basically our outcome is dichotomous. So it's in to good to excellent self-rated health. The reference group is, of course, the folks who aren't making that transition. So simple dichotomous outcome with reference group, the folks who aren't making that transition.
And that's why actually one of the nice things about here, about this technique is when you get that negative estimate, they know they're less likely to transition, shall we say, to the good to excellent.
Great question. In some of Heather's, she's also shown that the use of medications has this negative AAF bad outcome. So that makes intuitive sense that the use of medications is protective against some of the bad outcomes, which is why we take the medications in the first place.
Great. Thanks so much for that clarification. We have a question from someone who's familiar with MEPS data, and they believe there's ICD-9 codes for chronic conditions available in the provider file of the data set. And back to just using self-report of the chronic conditions in the survey, or are you aware of that validating potential? Have you looked at those codes for chronic conditions in the data file?
Terry is also working on this project with MAPS, and we have spoken to personnel at MEPS about this on a number of occasions, because we do understand how important it is to express in an accurate and precise manner these conditions. And based on our conversations with them and wanting to actually have utilization across a number of different categories, it appeared from our discussions with them that these were the priority conditions that were asked at these rounds, and so they were decided upon by MEPS in advance. And so in our discussions with personnel there, we took their advice to continue on to use those.
Thank you. I've gotten through as many questions as we have time for. We're reaching the end of our time. I just wanted to give a final thank you to both of you for great presentations. We really appreciate the time. Our next slide says if you have any questions about the webinar, you can contact Catherine at the email on the slide. I hope everyone has a wonderful afternoon, and thanks again for spending an hour and a half with us. I hope you learned a lot.